It is my pleasure to welcome Dr. Dosen, who just finished his Interventional Cardiology Fellowship at Stanford University. Today, we will be discussing his JACC Interventions manuscript, assessing the outcomes according to coronary disease complexity and optimal thresholds to guide revascularization approach. Dr. Dosen, thank you so much for taking the time to join us and share your expertise.
Thanks so much. Yeah, thanks for the opportunity to talk to you.
First, can we kind of give us brief background about the topic, the questions that you and the team aim to address, and the population that you studied?
Yeah, absolutely. So the topic of the study really was to look in a bit more detail at the syntax score. So the syntax score has been was initially published in 2009 from the syntax trial, and they divided their cohort into three tertiles. So with the lower cut point being less than or equal to 22, but that was kind of just where the tertile fell. And so since that time, it's been found there's sort of good effect modification with using the syntax score to assess coronary complexity and determine whether PCI versus CABG is a reasonable alternative. And so most commonly in clinical practice, less than or equal to 22 is used as the cut point for that. So that what we aim to do is to assess whether that cut point of less than or equal to 22 is an appropriate cut point or whether it's something different, lower or higher. And we wanted to sort of closely look at the assumptions as to whether coronary complexity had a linear or non-linear effect modification with PCI versus CABG outcomes. So to do this, we used the FAME3 cohort. So that was a recently published trial. The 3-year data were published last year. And so it was a non-inferiority trial looking at fractional flow reserve guided PCI versus bypass surgery for multivessel coronary disease. It excluded people with low ejection fraction. There were 1,500 patients, and in our cohort, we had 1,444 patients that had available syntax score data to include. So what we ended up looking at was to develop several models to look at the nonlinear effects. So and we found that the effects are nonlinear. So it doesn't as the coronary complexity increases, it sort of flattens off and then curves down, and there appears to be above about a syntax score about 40-ish or so. The curves go back across zero. So we then kind of used some modeling techniques to find where the optimal threshold is for syntax score for when, if you're below that threshold, whether PCI is a reasonable alternative to CABG. And we found that that was actually at 24, so less than or equal to 24. And using that threshold, it seems small, only 2 points, but using that threshold, you can identify a large proportion of patients that PCI is appropriate for, or may have similar outcomes for. Yeah.
Yeah, thank you so much. That's a kind of a very nice summary of the results. How do you think we should incorporate these results in, as you mentioned, even though it's just only 2 degrees, how do you think this will change practice or how we can incorporate this in clinical practice?
Yeah, I mean, it's a little tricky. I mean, I'm not sure that everyone necessarily uses the syntax score on every patient with multivessel disease. It's sort of a little bit complex to calculate it in everyone, and there's a fair bit of inter-user variability in terms of deriving the score. But what kind of the study suggests is that with patients with multivessel coronary disease, if you are using the syntax score, you can be a little bit more lenient in terms of when you would recommend that they definitely should get CABG, and CABG is going to have better outcomes versus PCI being an option. That's really the main kind of conclusion of the study, essentially.
Yeah, absolutely. And thank you so much, Dr. Dorson, for joining us today. And we invite everyone to go over the full manuscript published in this issue of JACC Interventions. Thank you again.
Thanks so much. Yeah.